stop. Vibration sense using tuning fork. This is one step ahead, and this can quantify the same test. We'll again test it on the upper extremity. Just you have to say if you appreciate at what time, at what stage you appreciate the vibration. Either say loudly yes. Now I'll apply it on the bony prominence, and you increase the voltage. You can see the voltage is being increased to 6, 7,
Yes.
10. He said yes. Next. Again start 0. 0. Right? We start. You tell me when you feel the vibration.
Yes.
So at 6 or 7 he is dead. So he is absolutely normal as far as upper limbs are concerned. Now we'll repeat it on the lower limb. Raise the voltage.
Yes.
So 7 or 8 he is appreciating. Raise.
Yes.
Again 6 or 7. So it's almost equal and within normal. In patients who have loss of protective sensations, you go on increasing the voltage to 15, 20, 25, 30, and they just keep silent because they cannot appreciate the vibration. So their VPT, vibration perception threshold, increases. Normally it is up to 15. In this case it was less than 10. But in cross section of the people, you'll find it between 10 to 15. But in patients with loss of protective sensation, it will be beyond 15. And those who have total loss of protective sensation, it will be beyond 25. Some people appreciate it at 40 or never appreciate. Now we'll also do the blood supply testing using the handheld Doppler. The peripheral pulsations, blood supply to the feet. The first test that I have told you is to look for the peripheral, feel for the peripheral pulsations. That we have seen. Now we can again quantify it using a simple instrument, what is called as handheld Doppler. So this is handheld and this is the probe, and it can detect the pulsations in the peripheral vessels as well as the upper limb. The normal basic principle you have to remember again, when we measure systolic pressure in the upper limb and lower limb, the systolic pressure in the lower limb is more than upper limb. And therefore, this is ankle pressure and this is brachial pressure. If we do a ratio ankle to brachial ABI, it will be always more than 1. But patients who have obstruction in the vessels in the lower limb, the blood supply is reduced, the systolic pressure in the lower limb will be lower than upper limb systolic pressure. So what you need to do is tie a sphygmomanometer cuff here and use a BP apparatus, or if you have an inbuilt machine you can use that, but otherwise BP apparatus can be used and inflate till the sounds disappear, and that is the systolic pressure in the upper limb. And I will demonstrate how the sounds are seen on Doppler. And then you apply the cuff over the calf and again inflate it till the sounds disappear. That will be the systolic pressure of lower limb, and again start reducing the pressure and note exactly when the sounds reappear. That will be the systolic pressure in the lower limb. Similarly, systolic pressure in the upper limb can be measured. Can you show me the dorsalis pedis, for example, in this foot?
So you just come this.
I think you can appreciate the peripheral pulsation sound. This is so. Now, if you apply sphygmomanometer cuff and inflate the cuff till this sound disappears, note the systolic pressure. Then allow it to come down. When the sounds reappear, again note down the systolic pressure. So that will be systolic pressure in the lower limb. For posterior tibial, you apply it here, behind the medial malleolus. Again, so this is ankle, and you can also measure on the brachial. This is not arterial sound. Now it is arterial. And you measure the systolic pressure by applying a sphygmomanotrachea. And then you can take out the ratio of ankle to brachial. The patient is asked to put his foot, yes, and yeah, you can still take it. Now you can remove the foot, because the black color is evenly distributed on the entire foot, and you can appreciate the medial arch of the foot. In patients who have neuropathy with deformities, you will find dark areas either on first head of metatarsal or wherever there are bony prominences, you will find dark black areas. And in patients who have sharper foot, this medial arch, which is classically seen as a concavity, collapses, and therefore instead of concavity it becomes almost convex, and that's the sign of sharper foot. Depending on the pressure points, you can then advise the patient proper insoles and redistribute the plantar pressure evenly so that this ulceration risk is reduced at those sites. Thank you. Basics of protective footwear. The footwear for majority of our diabetics should be like this. Almost 90% of all our diabetic patients need preventive footwear. They do not need any specialist or special footwear made for themselves. Simple footwear with some characteristics have to be followed in those footwear. For example, if you look at this footwear, there is a back support or a counter. These are Velcro belts. So if the patient gets little swelling of the feet, he can adjust the belt, and the feet, swollen feet also can be accommodated. There are soft insoles and rigid outsole. If you look at the inside of the footwear, you'll find there is no traumatic element here which can traumatize the feet. There was one boot. Example of another protective footwear, or for patients with a rigid outsole, and this is little broad and tall, and the insole which can be inserted here to make it a soft insole. And these are not meant for patients who have deformities or have lost their toes or have had amputation in the past. For them, we have to make special footwear, for example, like this. Now this has been tailor-made for that patient. You can see how broad is the foot. It is, the toe box is tall. And this is what I meant, the rigidity of the outer sole. It should not be. You cannot bend. So this is a rigid outer sole. This is what I was referring for the outer sole. It should be rigid, like this. And again, there are Velcro belts, and there is a soft insole. So this is an example of tailor-made, custom-made footwear for patients who have foot problems, deformities, or previous amputation or ulceration. These are meant for about 5 to 10% of our diabetic patients. And for such things, we can take the impression, this is a soft material on which the patient can put his foot, and you get a complete picture of the patient's foot, the shape. Wherever there are bony prominences, you will find such dimples, wherever the bony prominences are. And then the orthotist or footwear technologist, they can put plaster of Paris and prepare a special last and make an insole like this and prepare a last and make a tailor-made footwear for such patients. So these are very good, and this, show me this. This is a box. So once you have taken the impression, you can close it, seal it off, and send it to your orthotist wherever he is working. It could be some metro city or city 500 kilometers away from your workplace, and he can prepare insole as well as the footwear based on the information. So this is for one foot, this is for another foot. Because sometimes the deformities are more in right and less in left. So the footwear will be different for left and different for right. So we have to send to the orthotist left, right with proper labeling and giving the history to the orthotist, and he'll send us the insoles and the footwear. These are the used for offloading when patients have non-healing recurrent plantar ulcers, because most of the patients are not willing for TCC or total contact cast with the plaster of Paris. They like to have a removable cast. This is an example of a removable cast which can be worn by the patient, and he has to ensure that throughout the day, whenever he puts pressure on his feet, he has to be with this. Then only the purpose can be served and the offloading can be achieved. Another offloading device, also referred as a half shoe. You can see this is how it will be when the patient is wearing, and if he has ulcer on the forefoot, while walking, the pressure underneath the forefoot will be offloaded, and he'll be walking mainly on the sole which is touching. Walking with this footwear is not easy, so they should be instructed to walk slowly and take small steps. And same height should be given to the footwear on the other side. Otherwise, it will lose the balance and patient will fall. This is the example of cotton socks, protective socks for patients. As I have told, the sock should be cotton and should be preferably white, so that if there is any blood stain or any other stain, spouse or some family member can easily detect. They should be changed every day, and new pair should be worn, and they should be sent for washing. And the feature in this particular sock is there are no stitches, so there is no chance of traumatizing the feet when the socks remain in contact with the feet for long. Can you walk here? Great toe. The great toe is now not touching the feet, not touching the ground. It is the midfoot and the hindfoot which is touching. So almost first metatarsal head and great toe are offloaded. So if the patient has recurrent ulcerations on the forefeet, this shoe can help in offloading the pressure. Next. ठीक है?